I can imagine the different things running through your mind when you look at this image. Like, he's never gonna make it. He's not gonna make it move even an inch. But then, that will mean you shouldn't continue listening to me because I will tell you some very challenging things, which may seem impossible to overcome. But if you're one of those who believe in possibilities, then by all means continue. If not, continue anyway. What you learn might make you change your mind. So back to serious business. I will tell you about the different challenges that many countries face to provide essential vaccines for their communities, despite the many efforts that are in place to ensure adequate access. Not everyone eventually gets these vaccines, despite all the efforts invested. You might be asking yourself, why not? Well, there are several reasons described to limit vaccine access, but you might understand that this exists less by accident but more by design, that the challenges are expectedly most prevalent in low and middle income countries, and also most of the obstacles can be easily averted if given proper attention, as it is the case in some countries like Tanzania. For instance, in Tanzania, the Clinton Health Access Initiative has set up strategies to improve vaccine access to the most remote communities through local vaccine storage and supply chain strengthening. The results have been impressive with the rise of vaccine coverage in the entire country. Unlike Tanzania, several countries don't have access to basic vaccines due to several factors, including economic and political issues, infrastructural, logistic and demographic issues, manufacturing and production issues, socio-cultural issues, which we'll discuss in details in this lesson. We start with the most exciting but challenging obstacles. Let's begin with different monetary issues that may prevent some low-middle income countries from getting access to essential vaccines. In the past, vaccine manufacturers were able to sell vaccines to developing countries at a lower cost because they could get a higher price from industrialized countries. But some things have changed since then. For instance, industrialized and developing countries no longer use the same vaccines, and except from the hepatitis B vaccine, there is no longer enough competition among suppliers to keep prices down. Looking at our little image down there, we notice that the prices of vaccines have increased over the last years. Secondly, as you learned from the previous lesson, Gavi provides support for vaccine purchase for some low-middle income countries who meet the criteria for support. Unfortunately, some non-Gavi supported middle-income countries are still unable to appropriately finance vaccine purchase, and so they are lagging behind both high-income and Gavi supported countries with regards to introduction of new vaccines, as you can see in the graph. Although this disparity may reflect independent evidence-based decision-making, this also highlights obstacles to access. Today, a total immunization bill of $35 billion has been estimated by WHO for providing equitable access in poor countries, but only $25 billion is currently available, meaning that a lot of money is still needed to attain full access to vaccines. Finally, with respect to industrialized countries, with the US as example depending on insurance type, whether private or public, each insurance plan will fragment their access to vaccines, leaving some people without access to some essential vaccines. We all must be aware of the role of the government in healthcare issues. They get to decide what's best for the people. The primary political hindrance to vaccine access could likely be competing priorities, where low priority is given to vaccination programs, probably due to a lack of knowledge on the value of vaccines. Example, the delayed uptake of rotavirus vaccine in many low-middle income countries. The graph shows the uptake of the rotavirus vaccine from 2006 to 2017. You can note the difference between the different regions. Also, there might be suspicion of true motives and fear of exploitation, which was the case in Pakistan in 2011, where the CIA organized a fake door-to-door vaccination drive in one of its cities, hoping to locate Osama bin Laden. I'll let you picture the faces of these guys once they found out. But then these things happen, don't they? Again, some countries prefer to purchase their own vaccines, even in limited capacity, for the sake of maintaining national autonomy. The best example here is Cuba. Finally, due to several reasons, government funding levels tend to fluctuate, and disease outbreaks often follow a lessening of commitment to vaccination programs. Now we'll look at the possible obstacles to vaccine access in the field. In many low, middle-income country settings, healthcare systems are fragile or inexistent, with few and/or inadequately trained health personnel, vaccine storage space, disease surveillance data to estimate disease burden, etc., which have a huge negative effect on community access to vaccines. They might also lack the means to access, evaluate, and implement new vaccines. Vaccine delivery systems have remained largely unchanged in low-middle-income countries due to challenging contextual factors that have limited their ability to meet immunization program requirements. In these countries, the difficulty is multiplied by faster population growth and the lack of infrastructure to provide the appropriate schedule for each vaccine being administered. Moreover, many people still live in settlements with no roads, electricity, or phones. Therefore, contacting potential recipients and then delivering vaccines requires an immense effort. For instance, a mass immunization campaign against polio held December the 6th in 1998 required in India alone the coordination of 2.6 million healthcare workers and volunteers who traveled by bus, camels, and even on foot. The lack of controlled and well-managed supply chain maintenance abate vaccine distribution as well, at district level, especially the cold chain maintenance. Cold chain problems have resulted in risks to reduced potency of administered vaccine and poor availability of immunization supplies due to inadequate storage capacity, disrupted service delivery, etc. Finally, 1 in every 3 countries in the world experiences at least one stockout of at least one vaccine each month, which is usually due to inadequate demand forecasting, loss due to extreme temperature, inflexible purchasing mechanisms preventing manufacturers from reacting swiftly when vaccines are scarce. Changes in the manufacturing processes resulting in a decrease in production as well. How about the effect of vaccine development and production on vaccine access? For the most part, global vaccine development at large scale is done by the big pharma companies, but only few of them existing. They cannot meet global demand. You may be wondering why there are only a handful of companies producing vaccines. Well, there are significant investments in clinical trials, supply chains, including cold chain equipment and maintenance staff for vaccine development, making it rather difficult for smaller companies to invest in such ventures. However, there are several medium-scale emerging suppliers around the world producing vaccines for local use, like the Butantan Institute of Brazil and some other institutions in Cuba. Most emerging vaccine developers have a limited production capacity due to limited funds to invest in manufacturing buildings of large capacity. This results in delays in the introduction of new vaccines into certain countries. They can be also limited by little access to research results that may lead to new vaccine constructs, but also limited access to innovative vaccine technology. Diversity of country-specific product and packaging requirements creates also some inefficiencies. For example, the demand for thermostable vaccines, easy administration, fewer doses of vaccines to avoid wastage are difficult to develop. Increased and diverse regulatory requirements worldwide lead to significant difficulties in planning and production. These constraints significantly reduce supply flexibilities in terms of products that can be supplied to specific countries. They also increase lead time that impact vaccine availability for population. Did you know that it takes approximately 7 years for a vaccine to reach effective population access following application for marketing authorization? Long time, right? We've learned some good stuff back there, didn't we? Could you try to propose some of the societal issues that could hinder vaccine access? No? Well, we'll talk about a few of them. Migrating population, despite their reasons of migrating, are vulnerable, and several problems may limit their access to vaccinations, including the fact that they are not steady and many vaccines require multiple doses at regular times. Understandably, migrants often refuse registration with medical authorities in hosting countries for fear of legal consequences. Corruption diverts much-needed resources away from healthcare delivery as well. Examples include medical staff in public sector healthcare institutions who sell vaccines that should be free, thereby reducing availability for the whole community. Also, huge government embezzlements diminish the country's resources needed for healthcare investments. Also, rumors and conspiracy theories are known for their role in behavior modification and influence. In one instance, the widespread reports of forced sterilization in 1970s in India caused many to distrust the anti-polio campaign in the country. Other challenges that could result in reduced access to vaccine include language barriers, religious beliefs, health illiteracy, etc. How about natural factors that might be out of our control, like storms, floods, and earthquakes? These might have a huge impact and will be described in more details in your next activity. So, the point is, well, we've seen that there is no one-size-fits-all the obstacles to equitable global vaccine access, and we can conclude that every challenge may be sitting and country depending and could be further related to other factors which we haven't discussed. But it is a growing concern which results in over 19 million unvaccinated infants around the world. 65% of them reside in developing countries. You can do some deeper research to find out other challenges that we might have missed. Our guy here passed out during the presentation after all the pushing, but I'm hopeful he will survive it. Find out how in the next lesson. Thank you for your listening.